Pain Management After Video-Assisted Thoracoscopic and Open Surgery by Shanda Blackmon, Professor of Surgery, Mayo Clinic, Rochester, Minnesota. I would also like to take a moment to thank Dr. Linda Martin, who assisted in acquiring some of these slides and also assisted in reviewing this management strategy as well as the ERAS strategy. I have no relevant disclosures related to this presentation, and I will not be discussing off-label device or medication usage. I'll begin by describing different types of pain pathways, descriptions of options to modulate these pathways, and a review of opioid studies, and also a description of the problem. I'll go through some of the new studies and findings with regards to opioid reduction, enhanced recovery pathway, and pain management, and pain with downstream effects. And then we will conclude with a summary. If you Google the most painful incision, a thoracotomy is likely the most common answer you will get from patients and on the internet. Mechanisms involved in post-thoracotomy surgery pain are nociceptive and neuropathic in nature. They contain both somatic and visceral afferents. Nociceptive somatic afferents are transmitted by the intercostal nerves and are related to rib retraction, muscle splitting, injury to the parietal pleura, and the chest tube. Nociceptive visceral afferents are transmitted by the phrenic and vagal nerves and are activated by surgical trauma of the bronchi, visceral pleura, and pericardium. Various inflammatory mediators like prostaglandins and histamine, release as a result of surgery and enhance the activity of nociceptors. Nociceptive information results in the activation of neurons in the posterior horn of the spine, as well as the central NDMA, or N-methyl D-aspartate receptors. Neuropathic pain in thoracic surgery is usually the result of injury to the intercostal nerves and manifests as allodynia and hyperalgesia. Patients undergoing thoracic procedures frequently experience pain to the ipsilateral shoulder. This is called referred pain, and it's caused by the irritation of visceral pleura of the chest tube and stapling of the bronchus. Due to the multifactorial origin of pain in thoracic surgery, utilizing a combination of analgesic approaches targeting different pathways is a logical step in tackling lung resection pain. Gabapentin is used to treat neuropathic pain and blocks the development of hyperalgesia, reducing central sensitization. Acetaminophen is a centrally acting analgesic and antipyretic, potentially modulating the endocannabinoid system in the brain. Non-steroidal anti-inflammatory drugs inhibit the COX enzyme, preventing inflammation and prostaglandin synthesis. These are useful in reducing opioid consumption and testing referred pain and treating referred pain to the ipsilateral shoulder. IV ketamine works on blocking pain at the central levels by inhibiting the NDMA receptors and thereby decreasing central sensitization. IV opioids are the most frequently used therapy, and they act both peripherally and centrally on mu receptors. Local anesthetics result in blocking both somatic and sympathetic afferents from dermatomes above and below the site of paravertebral blockade. According to the STS General Thoracic Surgery database, we are responsible for distributing more than 800,000 tablets of oxycodone into the community after thoracic surgery. Much of this goes unused and in actuality feeds the opioid crisis. Thoracotomy results in a 2.5 times increase in prolonged opioid use, with video-assisted thoracoscopic surgery still not far behind. Up to a quarter of patients are still using opioids for pain 90 days after surgery, where this is only 3% for other smaller elective cases. And dose is dependent on the severity of the pain. There are many related adverse events, most happening with opioid-naive patients. Our group recently presented data at the Society of Thoracic Surgeons meeting in the past few years measuring 3 things: the quantity of unused opioids left in the community after thoracic surgery, the reduced need for opioids after minimally invasive thoracic surgery, and the possibility of reducing prescription to limit that volume of opioid medication available in the community. The senior author in this particular study was Elizabeth Haberman, and the first author was Dr. Kimberly Holst, who's one of our preeminent thoracic surgery residents specializing in cardiac surgery. This odds ratio plot clearly demonstrates the statistically significant increased odds of requiring opioids if a patient had a thoracotomy versus a VATS procedure like ours. Minimally invasive thoracic surgery in most studies resulted in less demand for opioids due to less pain. You can again see the two different hazard groups with the confidence intervals, showing that thoracic procedures done in a minimally invasive fashion had far less opioid use and a quicker time to ceasing opioid consumption by procedure, thoracotomy versus MIS. Similar findings were demonstrated in a new way, showed the opioids consumed in blue versus that remaining but unused in red. The overall amount was less in the minimally invasive surgery group, as well as the volume of that consumed. We therefore developed evidence-based guidelines for discharge opioid prescribing in concert with facilitating safe opioid disposition. This is required for patient-tailored pain management and reduction of unused opioids remaining in the community. Alex Bresica and the Michigan group presented a very nice infographic and article on factors associated with the new persistent opioid usage after lung resection, demonstrating that 14% of opioid-naive patients had new persistent opioid usage after lung resection, and then showing a 2.19 odds ratio with a 95% confidence interval for those patients undergoing adjuvant therapy. That means that patients undergoing adjuvant therapy were twice as likely to have opioid dependence. Another odds ratio was 1.58 for thoracotomy versus minimally invasive surgery, meaning that patients undergoing an open thoracotomy were 1.6 times more likely to have prolonged opioid usage after lung resection versus those patients having minimally invasive surgery. When choosing a regimen for pain control for patients requiring lung resection, one must weigh three factors against one another: pain relief, side effects, and other benefits. Although there are no randomized trials, this is one of the most intriguing ones. It's retrospective, and there are a lot of flaws, but they were able to demonstrate lower mean opioid use in those patients treated with GNA with no difference in NSAID or antiemetic requirements. Gabapentin and acetaminophen are very controversial, as many of the anesthesia colleagues doubt the actual effect of gabapentin in reducing overall opioid use. There are multiple different ways to acquire local pain control without the use of systemic opioids or drugs, and one of these is the thoracic paravertebral block. A short beveled needle is inserted 3 centimeters lateral to the most cephalad aspect of the spinous process and is advanced perpendicular to the skin in all planes to contact the transverse process of the vertebra below at a variable depth of 2 to 4 centimeters. The needle is then walked above the transverse process and gradually advanced until a subtle pop is felt as the needle passes the thin superior costotransverse ligament. Gentle aspiration, followed by injection of local anesthetic, is performed. A serratus anterior plane block is another option for adequate pain control. Serratus anterior plane blocks are blocking intercostal nerves and can block any of those from T2 to T9 in the lateral cutaneous branches only. The long thoracic nerve will have to have blockade of the serratus muscle, and the thoracodorsal nerve going to the latissimus muscle may also be blocked. Only somatic analgesia is achieved in this type of blockade. No visceral analgesia is achieved. You can see the space in blue between the latissimus muscle, the serratus muscle, and the teres, which is where the injection is performed, and ultrasound guidance can sometimes help guide the injection. An intercostal nerve block is the most common type of block that is utilized during minimally invasive surgery, and this involves a short beveled needle that is inserted into ribs 2 through 12. You can choose appropriate injection to limit fewer ribs with more anesthetic if chosen. Superior part of the intercostal space is entered as the needle is directed towards the lower border of the rib. The anesthetic is injected close to the subcostal groove and infiltrated around the nerve. This is best if blocked before the lateral cutaneous branch, which is located in the anterior axillary line. We have presented a comparison of the 4 different regional anesthetic techniques for video-assisted thoracoscopic surgery. These 4 different techniques include thoracic epidural anesthesia or analgesia, which is the most common traditional form, a paravertebral analgesia, intercostal analgesia, and intrapleural analgesia. The analgesic coverage varies between these different types of procedures, with TEA giving bilateral coverage, paravertebral giving unilateral coverage, as well as intercostal and intrapleural. The benefits are excellent analgesia with the thoracic epidural, less hypotension, urinary retention than TEA seen in paravertebral analgesia, and even less minimal incidence of hypotension with intercostal nerve as compared to epidural. The intercostal nerve has the additional advantage of being easy to perform during video-assisted thoracoscopic surgery and has minimal effects on pulmonary function. Intrapleural analgesia has minimal incidence of hypotension as well, has no nausea, vomiting, or urinary retention, can be performed during video-assisted thoracoscopic surgery, and also has minimal effect on pulmonary function. Some of the risks and side effects are seen in the column to the right. The most dreaded side effect of epidural analgesia is that of an epidural hematoma, abscess, dural puncture, urinary retention, or nausea and vomiting. The side effects are fewer the farther away you go from the spine, as the paravertebral analgesia has the risk of pneumothorax, neuraxial spread, or intrapleural injection. The intercostal analgesia has the side effects of pneumothorax, hemothorax, IV injection, and toxicity. And the intrapleural analgesia has the risk or side effect profile of catheter misplacement, LA loss by the chest tube, pneumothorax, or toxicity. When comparing different studies using thoracic epidural analgesia in VATS patients, there are at least multiple different studies published ranging from 2006 to 2009 that are covered. Thoracic epidural blocks do work to minimize pain, but they're costly and they require additional teams to manage. When looking at studies using thoracic prevertebral analgesia in VATS patients, we've discovered that paravertebral blocks do work, perhaps better than intercostal nerve blocks, as well as minimizing the pain. When analyzing studies used with intercostal or intrapleural analgesia in VATS patients, I surmise that intercostal blocks do also work to minimize pain and narcotic use, but sometimes are a little bit more difficult to manage and don't last as long unless Exparel is used and redosing is implemented. Pain management after VATS has the following published algorithm, which I found incredibly helpful. Local regional analgesia is preferred along with systemic analgesia. Thoracic paravertebral block, ultrasound-guided serratus anterior plane block, or intercostal nerve blocks are all good choices for regional control. Recommendations are to implement this at the beginning of the case to reduce the intraoperative requirements for IV medications during the surgery. Sometimes injection at the beginning of the case may take as long as 1 hour to start to take effect. When used in conjunction with systemic medications, we find that this methodology works best. It is important to understand how enhanced recovery systems are related to pain. An enhanced recovery program is associated with improvement in many short-term outcomes, including lower postoperative morbidity, less pain, shorter length of stay, and an increase in overall patient satisfaction, as published by multiple papers. The shorter the duration of air leak and chest tube duration, the less pain. Therefore, we do everything we can to get the big chest tube out as quickly as possible, to seal the lung as quickly as possible, to use the smallest tube as possible, but yet big enough to be able to appreciate bleeding and drain bleeding, and to use minimal suctioning. There was a particular randomized controlled trial published by Kui et al. That looked at patients who were randomized to drainage ball with low negative pressure versus chest tube with water sealed bottle after VATS lobectomy. They were able to randomize 60 patients, and they concluded that the lower pain score, less analgesia was used, less drainage time was required, and shorter length of stay. Again, after VATS lobectomy, using a drainage ball with negative pressure could reduce hospitalization days and postoperative pain compared with the more commonly used chest tube with water seal bottle. Although this is unconventional, it is thought-provoking. Again, showing lower pain score and less analgesia requirement. In this particular publication from the ESTS releasing 45 enhanced recovery guidelines to minimize pain, the key question was, what is the optimal perioperative management for patients undergoing lung surgery? Recommendations were developed for 45 enhanced recovery items from initial presentation through postoperative discharge. The use of a systemic multimodal perioperative care pathway has the potential to improve outcomes after lung surgery. Some of the 45 enhanced recovery guidelines to minimize pain are delineated in this list. With regard to chest tube drainage management, the routine application of external suction should be avoided. Digital drainage systems reduce variability in decision-making and should be used. Chest tubes should be removed even in the daily serous effusion is of high volume. A single tube should be used instead of 2 after anatomic lung resection. However, I would add the caveat that in some of our practices, especially mine, I place a small pigtail at the top of the chest to continue to drain air in the event of a prolonged air leak, as well as a chest tube, and remove the chest tube in almost all circumstances post-op day 1. Their recommendations regarding urinary drainage reported that in patients with normal perioperative renal function, a transurethral catheter should never be routinely placed in the sole purpose of monitoring urine output. They also concluded that it is reasonable to place a transureteral catheter in patients with thoracic epidural anesthesia, and that these do not have to be early removed, as proven in the randomized trial published by Mark Allen and colleagues from Mayo Clinic in the Annals of Thoracic Surgery. With regards to early mobilization and adjuncts in physiotherapy, recommendations were made that patients should be mobilized within 24 hours of surgery, and prophylactic mini tracheostomy use may be considered in certain high-risk patients to minimize the result of pneumonia. There are many advantages to a digital drainage system. Many of these are underappreciated. Digital drainage systems provide balanced suction. They are easy to read. They promote mobilization. They have 24-hour registration of fluid output and air output, making the question of whether or not an air leak is present less subjective. They also result in earlier removal of the chest tube. Thus, they also result in less pain. The effects of low suction on digital drainage devices after lobectomy using VATS surgery in a randomized control trial was published by Renee Pedersen and colleagues. They took patients undergoing a VATS lobectomy and randomized 230 patients. The first group received -2 water suction in 115 patients, and 111 were analyzed. The other group that it was randomized against had -10 centimeter water suction in another 115 patients, and 111 of those were analyzed. They show the hazard ratio and the confidence intervals with those patients undergoing -2 versus -10 centimeter water suction. Those patients that had less water suction applied had a shorter air leak duration. When you look at the drainage duration, time to air leak cessation, and time to removal of drain, all of these were less when the suction was reduced to -2 centimeters as seen in their variable analysis. The primary and secondary outcomes again concluded that drainage duration, time to air leak cessation, and time to removal of the drain were all less when the suction was reduced to -2. The only caveat I would report here is that if the patient develops massive subcutaneous emphysema, a higher suction might be required. Drainage duration, time to air leak cessation, and time to removal of drain again were less in each of these, as the graphic abstract shows to the picture to the right. There are multiple other enhanced recovery programs, such as those in the VATS Copenhagen group, and I would like to thank Renee Pedersen for sharing his outcomes and his enhanced recovery program. They performed video-assisted thoracoscopic surgery in 88% of all lung cancer patients, all comers, in 2018. Almost all of those patients presenting with early lung cancer certainly underwent minimally invasive surgery. Their group is divided into a minimally invasive and a maximally invasive group, and only patients who have early lung cancer are referred to the minimally invasive group. Patients who present with locally chest wall invasion group patients will often be referred to the maximally invasive surgeons. Maximally invasive open surgeons do not get early lung cancers referred to them unless they are able to acquire the skills to perform a minimally invasive resection. Multimodal opioid-sparing analgesia is employed in every patient. Intercostal catheters and paravertebral blockade is also utilized. Routinely, the group only uses one chest drain, which is 24 French in size. They utilize the Topaz Medela drainage program with suction place now at -2. They mobilize patients on post-op day 0, the day of surgery. Chest drain removal criteria is no fixed upper limit if serous output. If the output is chylous or bloody after a meal, then the drain is left within place. If the air leak is less than 20 over 12 hours, the tube is removed. They perform rounds every day by the operating surgeon. What about unexpected consequences of enhanced recovery pathways and controlling pain better? David Nelson and colleagues from MD Anderson recently demonstrated during an analysis of implementation of an enhanced recovery program enhanced delivery of patients to adjuvant chemotherapy. They found more patients getting and completing adjuvant therapy more quickly after they had enhanced recovery pathway applied to their care. As you can see, the Kaplan-Meier survival curves show that those patients in the enhanced recovery pre-ERAS in blue, transition period in red, and after the ERAS implementation in green, with the proportion of patients reaching ECOG performance status of 0 and a higher proportion of those patients involved in the ERAS recovery pathway. The rate of completing adjuvant therapy pre-ERAS was 40%, and after implementing the ERAS program, fully increased to 62% of patients. after implementation of an enhanced recovery program, patients at MD Anderson started adjuvant chemotherapy earlier. These patients were more likely to complete at least 4 cycles of chemotherapy. What are other reasons why we may want to limit opioid use? Some of these articles that I'm sharing are just thought-provoking, as no one has definitively proven that the mu-opioid receptor for sure promotes opioid and growth factor-induced proliferation, migration, and epithelial mesenchyme transition in human lung cancer. Some of these studies are severely flawed, but I do present the data showing some of the conclusions, such as in this particular study, where MDR overexpression was evident in lung cancer samples of patients with metastasis compared to lung cancer patients who did not have metastasis. Although this is not a direct relationship, it is thought-provoking. Another paper concluded that morphine may have a growth-promoting effect on lung cancer. They obviously are concerned, for more reasons than one, about opioid consumption in our lung cancer patient population. Naloxone would reduce the SUV by 40 to 50% in this particular study looking at PET scans applied to patients with invasive lung cancer. Another study showing the association of increased postoperative opioid administration with non-small cell lung cancer recurrence in a retrospective analysis. Again, although it is flawed, it is certainly thought-provoking. Another paper showing prolonged opioid use being associated with reduced survival after lung cancer resection. The inclusion criteria for this that was presented as a poster at the American Association for Thoracic Surgeons showed patients who had stage 1, 2, or 3 lung cancer were enrolled into Medicare as inclusion criteria. Patients were stratified by opioid use, whether they had chronic use, standard use, or prolonged use, and the primary outcome was risk-adjusted overall survival. The data source was the SEER Medicare database. They showed that the standard 42% product-limited survival estimate versus chronic opioid use 44% versus prolonged new opioid use of 13%, stratifying patients by opioid use and displaying them by survival, which was statistically significant. In a multivariable Cox proportion hazard model for overall survival, they demonstrated that chronic opioid use, prolonged new opioid use, both were predictive of survival, as was age, gender, stage, chemotherapy, radiation therapy, and single versus marital status. When looking at opioids and lung cancer survival, new prolonged opioid use developed in 24% of opioid-naive patients after lung cancer resection. Chronic and new prolonged opioid use were independently associated with worse long-term survival after lung cancer resection. There is some epidemiological support to the growing body of evidence linking opioids to lung cancer growth, progression, and metastasis. Is it okay to omit the chest tube, looking and transitioning from opioids towards the chest tube? In general, the criteria to omit or reduce the size of the chest tube to small drain, such as a 10 French pigtail, are in patients who might undergo a VATS wedge resection, be greater than 18 years of age, have an FEV1 and DLCO that are greater than 60% of predicted, speak English, have a small tumor less than 2 centimeters, and have a distance of tumor to the pleura less than 3 centimeters. Patients who have less than 2 separate wedge resections, have no air leak on initial test on the table, submerging the chest tube underwater in a bucket. Less than 30% lung adhesions, no bullous emphysema, no preoperative pleural effusion, and no coagulopathy. Renee Peterson and his group have published that these patients in this particular group are ideal to omit the chest tube in postoperative recovery. Another paper that is published looking at thoracoscopic pulmonary wedge resection without postoperative chest drainage as an observational study is published here. So I would like to push the envelope a little bit farther beyond small 10 French drainage tubes to what about no chest tube? Again, chest tube management for me personally is a pigtail plus a chest tube for bigger cases, and only a pigtail catheter, which can be converted from a bulb to a Medela device if needed. Less suction, -2 beyond physio, smaller chest tubes, and a pathway and protocol for chest tubes to guide residents and teams managing patients, with air leak less than 20 cc's per minute for more than 12 hours being the criteria for removal, and rounding on the patient every day. What about Exparel? Is it an urban myth that it actually works? The standardized cost is well published in the literature at around $300 versus the cost of an epidural, which might be even more. The needle size that is utilized for Exparel can be greater than 25 gauge. There is a theory that using needle sizes greater than 25 gauge may cause breaking of the liposomes, and sometimes physicians advocate using larger needles for injecting Exparel. There is no intraarterial injection, not as much of a problem because most of the Exparel is bound, and thus intraarterial injection of Exparel is expected to be far less consequential than intraarterial injection of lidocaine, which is free and unbound. No additional anesthetic medications, such as lidocaine, should be administered at the same time as Exparel. Although sometimes this rule is broken, it certainly does cause concern when multiple different agents are used, especially if they are released concurrently. The patient should be wearing an Exparel bracelet to identify them so that everyone is aware that the Exparel is on board and when it should be expired. Most of the Exparel works early, as some is unbound, but other portions of patients may need to have the Exparel injected at the beginning of the case so that it is available and active by the time the patient wakes up. What about post-thoracotomy pain syndrome? This is a syndrome that's related to intercostal nerve injury causing a neuroma, tumor recurrence, myofascial pain syndrome, frozen shoulder, healing rib fracture, costochondritis, costochondral disruption, costovertebral disruption, infection, pleuritis, and psychological distress. There is about a 50% incidence of post-thoracotomy pain syndrome after a thoracotomy, and about a 30% incidence at 4 to 5 years after surgery by this particular study cited below. Predictors of neuropathic pain after thoracic surgery include those patients who have a longer surgery and those patients who have preoperative use of hypnotic medication and are unable to complete with VATS. There is an increased risk of neuropathic pain after thoracic surgery, again, if the patient has preoperative use of hypnotic medication, undergoes a thoracotomy, which is an open thoracic incision, and has a prolonged surgery. The VATS approach could decrease the incidence of postoperative neuropathic pain regardless of the duration of surgery. There was a 25% incidence of post-op neuropathic pain in this particular study and a 19% incidence of post-thoracotomy neuropathic pain at 1 year after the time of surgery. This is a video of regional intercostal nerve block and how I do it at the time of surgery. We are placing the block in the intercostal spaces 3 through 10. I do not advise going too high. For the sake of visualization, we are also using methylene blue dye, which has been mixed with the Exparel at the consent of the patient. The patient has the Exparel mixed with saline and methylene blue dye, and a needle is placed from the outside towards the inside. Initially, the needle is passed towards the intercostal space as adjacent to the intercostal nerve artery vein bundle without going into the artery. We draw back on the syringe first to make sure that we are not getting arterial or venous blood back, and then inject with the goal of seeing the injection surround the intercostal nerve artery vein bundle. The Angle for injection can easily be seen in the image to the top left. On the image to the right in the video, you can see a very adequate injection at each of the intercostal spaces. Sometimes it's necessary to depress the diaphragm. Almost always, we recommend performing this at the beginning of the surgery before you begin to perform your lymph node dissection or lung resection. In summary, I'd like to review what I find helpful when managing patients for VATS as a take-home message. In summary, preoperatively, one should optimize nutrition. Patients should be provided with education videos. Smoking cessation should be implemented. We should reduce fasting periods, give antibiotic prophylaxis, give DVT prophylaxis before the patient is given general anesthesia, giving them the heparin and the sequential compression devices after the patient has been induced allows for less effective DVT prophylaxis than giving it before induction of anesthesia. The actual time of hypotension occurs at the time of hypotension with the general anesthetic administration. Warming the patient in the preoperative holding area, chlorhexidine scrub, sarcopenia assessment, shooting for a prealbumin greater than 17, carbohydrate loading the night before and 2 hours before surgery, prehabilitation, and having a contract for patients to postoperatively adhere to postoperative rehabilitation. Acetaminophen 1,000 milligrams post-op and on arrival, by mouth on arrival, and or in the waiting area, unless contraindicated. Intraoperatively, we begin with incisional and intercostal nerve blocks for ribs 3 through 10 in most cases, with Exparel plus intraoperative IV opioids as needed. We utilize the Topaz Medela digital drainage system, placing it at -2 centimeters water suction unless subcutaneous emphysema develops and we have to go up. We perform minimally invasive surgery whenever possible, and in my circumstance for stage 1 and 2 cancers, it's almost always minimally invasive, 98% of the time. Short-acting anesthetics, protective lung strategy, limiting IV fluids, running the patients relatively dry when a lung surgery is performed, shooting for normothermia, sealing all air leaks when feasible, performing a thoracic pleural tent and sewing the lung when necessary, allowing some permissive hypercapnia, placing a pigtail plus a chest tube so that the chest tube can be removed post-op day 1 in the event of a prolonged air leak. Toradol, which can be given at the end of the case. Consider 10 milligrams IV ketamine at the end of the case. Intraoperative nausea vomiting prophylaxis with ondansetron and droperidol and dexamethasone. Postoperatively, on post-op day 0, immediate mobilization. A less than 1,500 cc a day fluid limit for patients when drinking fluids. Avoid opioids. Repeat the intercostal nerve block if needed. Early oral nutrition. Physical therapy, occupational therapy, respiratory therapy on the unit. Utilization of a lung pillow. Pathways for nausea, pain, and DVT prophylaxis. Tubes and lines out as early as possible. Chest tube out on post-op day 1. Bulbs used if there's no air leak. Blood patch if an air leak. The blood patch is utilized as early as possible. Post-anesthesia care unit for VATS pain greater than 4, oxycodone 10 milligrams, fentanyl, and then repeating as needed. Hydromorphone 0.2 milligrams IV as needed for patients who have high pain. Pending clinical trials involve the trial by James Hannon, which has been performed here at Mayo Clinic, which is a randomized controlled trial for patients undergoing thoracotomy, where patients are randomized to epidural, which is the control, versus Exparel regional blockade. The VAS pain scores, morphine utilization are the endpoints. Early findings from this randomized trial for patients undergoing a thoracotomy. show the different utilization for patients on the first day with a cough, first day at rest, second day with a cough, and second day at rest. For those patients having an epidural versus an intercostal Exparel injection, and they are not statistically different so far. Looking at patients who are having an intercostal versus epidural pain also is seen to the far right with a bar graph. The goal of this controlled trial, published by Poonen from New York from St. Luke's Hospital, is to evaluate the difference in quality of analgesia between efficacy of serratus plane block and local surgical infiltration by the surgeon as measured by patient opioid consumption and pain scores. Another pending Alliance clinical trial is a randomized clinical trial pilot test evaluating the side effect and best dose of naloxegol to see how well it works in treating patients with stage 3B and 4 lung cancer. Naloxegol may relieve some of the side effects of opioid pain medication and fight off future growth in the cancer. Thinking outside the box requires us to constantly review the literature, to constantly consider things that perhaps we had not considered. In the bottom right video, you can see some of the Joel Dunning studies where they're actually using acupressure to help patients with pain control after surgery. Looking at thermography, planning for the future, potentially considering cryoneurolysis, and looking at novel ways that we control pain, helping our patients to have a quicker, more efficient, and faster, and more effective recovery. Take-home messages: limit opioids, but control pain. The Alliance trial looking at mute opioid receptor is thought-provoking. We need more randomized controlled trials for individual decision points. Post-thoracotomy pain syndrome is a real problem, and we should not be performing thoracotomies unless absolutely necessary. And when thoracotomies are performed, we should try to spare the latissimus and serratus muscle, at the very least, to provide the patient the best function after surgery. Reducing the pain with more minimally invasive thoracic surgery, a combined approach with regional blockade, and enhanced recovery is very important as we seek to reduce our recurrence of lung cancer, enhance pain control in our patients, and reduce opioid addiction. Thank you for your attention. I hope you found this presentation helpful. We appreciate your interest, and during this time, as we begin to innovate in thoracic surgery and push the envelope, please see what you can do to help us answer some of these important questions. Thank you very much.